A very big hello to all my dear students. So, welcome to the T2O series of your favorite channel, You and I with Dr. Ruchira. So, let's see what do we have in store today. We'll start today with a thought for the day. Reading this for you all. The biggest mistake is to give up on your dreams and not to challenge yourself for the fear of failure. Let's keep moving forward, telling ourselves, I will start from today. I will start fresh from this moment on. So, are we ready? Right. Let's start. So, we start with two case studies today and then we will shift to image based questions. So, today we are going to discuss a few image based questions along with clinical scenario. So, we take this first study. A young man, so we are talking about a young male here who is complaining of difficulty in blurring of vision in his right eye and then followed by left eye after a few months. There is disc hyperemia, there is, just ignore this, circumpapillary telangiectasia with normal pupillary response and centrocecal scotoma on perimetry. The cause is. So, did you get something here? If he has a centrocecal scotoma, it's a type of centroscotoma with the difficulty of the vision. Are we not, and disc hyperemia, we are talking about optic neuritis, isn't it? So let's quickly revise what are the features of any optic neuritis or optic nerve disease. So we can learn of the features by 5 fingers. What are the 5 fingers? This is how I teach. This is how I speak. So it is first decreased visual acuity. The vision in that affected eye will be less. Secondly, there will be visual field defects. Now, these visual field defects could be central scotoma, centrocecal. What is centrocecal? Centrocecal means when it is involving both the macula and the optic disc. Or it could even be altitudinal field defect as we have learnt in your ischemic optic neuropathies. So, whatever it is, mainly we are talking about there are field defects. Then very important afferent pupillary defect. So, there is a pupillary defect and the pupillary reactions are not normal. Then decreased color. What is that called? We call it dyschromatopsia. So the affected eye, there will be dyschromatopsia. And of course, lastly, we all know decreased brightness. These are the features of optic neuritis. Okay, so once we know these are features, and I hope you all remember this question, what is the first sign of optic nerve disease? We always say first sign is afferent pupillary defect. Is there any exception? Yes. This question is all about this exception only. In Leber's hereditary optic neuropathy, though all the features, it's an optic neuritis, we get all the features, but very important, pupillary reactions are no. There is no APD. Please keep this in mind. Now, why it is so, it goes a little higher level. Maybe I'll explain you sometime later. But you have to understand that the pupillary reactions are normal. Second feature, as you know, is telangiectatic vessels. These are permanent dilatation of the capillaries. Okay, this is what is showing in this fundus picture. So these are the telangiectatic vessels near the optic disc as shown in the arrow. Right? So it is very, very typical of what? We are talking about Leber's hereditary optic neuropathy. Look at the second slide. Slowly the optic disc is all becoming pale. First it was temporarily pale and then now the whole of the optic disc, it is showing you an optic atrophy. So any long-standing disease will lead to optic atrophy, isn't it? Now, when you talk about Leber's, can you see that what is the type of optic atrophy? Please revise your classification of optic atrophy: primary, secondary, consecutive, and glaucomatous. Now, I cannot go too much in detail in that direction, but very quickly, if you have learnt it in my style, a primary optic atrophy, chalky white, there's a CW and clear disc margin. So this is what you can see here in Leber's. So Leber's later leads to which type of optic atrophy? We will say it is primary optic atrophy. Okay, so this is another point to remember. What are the other options? Of course, it cannot be a typical case of optic neuritis because APD is not there. Acute papilledema is actually a different diagnosis, and there also pupillary reactions are normal, but papilledema, you don't get centrocecal scotomas, and the patient will vision is also affected very late. Normally, the vision is normal in the papilledema stage. So it's a very, very different story, papilledema. So this is wrong. Toxic optic neuropathy, you should remember this is also called toxic amblyopia. Please revise what are the drugs which can cause optic neuritis. सबसे पहले क्या याद रखना है? Tobacco, ethambutol, chloroquine, methyl alcohol. Okay, so revise all this. Right. So that was the first case study. So now you know the diagnosis here is Leber's heredity. It's a very obvious history, as if it has been made according. So I think this is an easy way. I'm just taking easy versions in the beginning. Okay. Next we talk about a second case study. Mein, a 19-year-old young girl with previous history of repeated pain over the medial canthus and chronic use of nasal decongestant. What does that suggest to you? Some type of sinusitis is there, right? And this, yeah, and presenting with fever, abrupt onset of fever, chills, rigor. There's moderate proptosis, chemosis. Very important, and the catch point here, which is mentioned, is diplopia on lateral gaze. So, what is the diagnosis? If I look at the whole question, so it's a case of sinusitis which has started presenting with proptosis and chemosis. My mind goes into, okay, it's as complicated as orbital cellulitis. But is this only orbital cellulitis or has it spread to the cavernous sinuses? How do we know that? Think yourself. If a case comes to me with proptosis and chemosis and I know it's an orbital cellulitis, I would definitely like to know whether his cavernous sinuses are involved or not. I have to prognosticate the patient. So I will look at the movement in the other eye, and what specifically I'm looking is abduction of the other eye. Why do I say other eye? Because this eye is proptosed, no? There can be some limitation of movement and due to proptosis. So I see the other eye, and in the other eye, if there is limited abduction, it is cavernous sinuses getting involved. Why? Revise your anatomy here. So can you see if these are the two cavernous sinuses, how it is connected? Why I said it is connected, so that it comes to your mind that once cavernous sinuses are involved, it is going to lead to bilateral proptosis. Anyway, I'll just come to that. What is important in anatomy? So everybody knows this diagram. It should be very, very thorough for you, with you. Optic chiasma, pituitary gland, and these are the sinuses. And what you have to keep in mind, 3, 4, 5 are along the walls. You can see the nerves. And 6th is in the body of the sinus. And this 6th, which is in the body of the sinus, is along with internal carotid artery. Right? Therefore, the first sign, the exam question again for you all. The first sign of cavernous sinus thrombosis, first sign is 6th nerve palsy. This is the reason we are looking at abduction of the other eye. Okay? So first sign is 6th nerve palsy. So here, because the history says there is diplopia on lateral gaze, it means the lateral rectus. 6th nerve supplies the lateral rectus. Sabko yaad hai na? LR6 SO4. So this is the reason there is diplopia towards lateral gaze. It is getting affected. There is LR palsy. Therefore, what is the answer? Cavernous sinus thrombosis. And remember, the most common sinusitis due to which you can get all these complications is ethmoidal only. Okay, ethmoidal sinuses when involved. This is again an exam question for you. So this is not the diagnosis, and why orbital cellulitis is not the diagnosis, I have just explained you. What is the orbital apex syndrome? When the superiorbital fissure and optic foramen area all are inflamed and involved, we call it orbital apex syndrome. Right? Again, in that, all the nerves which are passing through the superiorbital fissure should be involved. Okay. Then another thing is, and to add to that, of course, through the optic foramen, what are the structures passing? You know, na? Optic nerve and ophthalmic artery. So even that will be involved. Anyway, this is a case of your cavernous sinus thrombosis, and as I was telling you, now it is a bilateral proptosis with chemosis and congestion. I hope it's clear, right? Okay, so now we come to a quick glance at some image-based questions here. This is our first image. What is it? Simple first image. Tell me, what is this? Of course, it's a cataract. Which type? Can you see the onion peel appearance? So we are talking about posterior polar cataract. So जिसमें क्या मिलता है? Onion peel appearance. Now, this posterior polar cataract with the onion peel appearance, very important to keep in mind. When we are operating this cataract, there is a tendency it is adhered to the posterior capsule. So, what is the most common complication? We will answer posterior capsular rupture. Okay, so specific to this cataract, this is the question. What surgical complication is more common in cataracts, which are seen in the image here? So, our answer would be this is posterior capsular rupture. We come to the next image. Okay. Okay, look at this image. So whenever you are getting an image with the 9 gazes, please don't get intimidated. Oh, what to do now? So first of all, very quickly, you should be very clear about these 9 gazes where we are testing the movement of your eye. What, right? So this is the primary gaze looking straight. This will become looking straight to the right is dextro version, straight to the left, levo version. Now what is this? Dextro elevation, dextro depression, levo elevation, levo depression. Once you are clear with that, whenever this picture comes to you, look at the primary gaze. If I look at the primary gaze, what do I see here? I see that the left eye there is ptosis and the position of the eye is down and out. Can you look at this? So down and out with ptosis. Immediately we know it's third nerve palsy. Look at the look at this dextroversion. What is happening? There is a defective adduction here. It cannot adduct. But when we talk about levo version, here there is abduction is normal, right? Here the abduction, now you can see. So here the abduction is normal. So this is the third nerve palsy. So here we are going to answer third nerve palsy. Okay. We come to the next image. What is this? What is this image? Huh? What are we looking at? Colored rings around the light, colored halos. So, what are the causes except? Very simple question. So, the patient complaints are depicted in the image. The cause can be all except. So, what is the cause all except? You will answer acute anterior uveitis. We all know the cause of colored halos can be cataract, acute congestive glaucoma. You never say glaucoma. You always specify which glaucoma. Isn't it? Because it is only in this acute congestive glaucoma, or now we call it acute primary angle closure, that there is sudden rise of intraocular pressure leading to corneal edema, and that is the cause of colored halos. So always say acute congestive. Third cause is mucopudolent conjunctivitis. So all except this. A very recent question for you all. What is Finchem's test? It's an old question also, but again they have asked you recently as well. So what is Finchem's test? We are past, so patient is seeing colored halos. You pass a stenopic slit in front of his eyes. So looking through that slit, if his halos are breaking, then it is cataract. If not, it is acute congestive glaucoma. Okay, so please remember, if the halos break, then this is what? Cataract. If not break, now it is what? You will answer acute congestive glaucoma. Acute congestive glaucoma. Right? Okay, next one. So this is the next image here. What do you see? These are giant papilla on the upper lid. What comes in your mind? Vernal keratoconjunctivitis? But here the question says a contact lens wearer. This is a case of giant papillary conjunctivitis. Okay, so we should all know that one of the common causes of contact lens wear is giant papillary conjunctivitis. Wear your contact lenses very wisely. Okay, this is my personal advice to you. Never be very casual, touching the lenses with your dirty hands. Always wash your hand with soap and water. Okay, don't keep it wearing for too long time. And of course, you should not by mistake sleep wearing your lenses. Okay, that's not allowed at all. Right. So this is now. What are the other pictures of looking at what? How will trachoma look like? How will the vernal keratoconjunctivitis? So we all know this. Let's have a look. So these are the sago grain follicles of trachoma. We all know this, sago grain follicles of trachoma. Right. And what is this? Okay, the papilla are a little not very clear here somehow because of there is a pseudo membrane which is deposited over here. And what is the sign known as? Maxwell-Lorentz sign. Yes, we are talking about vernal keratoconjunctivitis, and this is your Maxwell-Lorentz sign. Okay, we come to the next image now. Look at this. What is this? We all know this ring-like structure on the anterior capsule of the lens is nothing but imprint of iris pigment. Why did that happen? Because of blunt trauma. Yes, we are talking about Vossius ring. First question, where is it situated? On the anterior capsule. What are these iris pigments? So they are imprinted because of that blunt trauma, and that is what is called Vossius ring. So this is the answer. What about KF ring? What about the other rings? Let's have a look. This one is Kaiser Fleischer. Golden brown ring near the limbus. Everybody knows this. It is due to copper deposition. Where is the copper deposited? Descemet's membrane. Look at this one. What is this? This is iron deposition. Iron deposition. This one, see, this one is more clear. So we are talking about Fleischer's ring here, not Kaiser Fleischer. Fleischer's ring क्या होती है? It is iron deposition. कहाँ पे? Epithelium. So which condition? Keratoconus, right? Keratoconus. When you talk about KF ring, we talk about calcosis, Wilson's disease. So we'll not forget these. These are very, very important questions of exam. ठीक है? Okay. Another ring. Which one is this? This is the immune Wesley ring. Okay, this is also important for exam. Immune Wesley ring. Mainly typical of, what do you see here? This is your fungal keratitis. I can look at this dry rough ulcer. I can see the hyphae and this fungal keratitis, which is a dry rough ulcer. Right? So what is this? These are immune Wesley ring. We come to the next image. What is this image now? Look at it. This investigation, what do you see? You are seeing a prism bar. It has a different strength of the prisms in form of a scale, right? Everybody knows for Hirschberg's test, if I have to diagnose a squint, I'm showing the torchlight in front. Suppose you are showing the torchlight in front of my eye. If both the reflexes are at the center, my eye is straight. Now imagine that you showed the torch and my eye was already deviated out. Where will the reflex come? Inside, nasally. If my eye is deviated in, where is the reflex coming? Outside. Right? Understood? So I haven't included a clinical picture here. I think it's clear to you all. So this is, what is Hirschberg test? What is the displacement of the reflex from the center? Normal se kitna away? So keep in mind 1 millimeter displacement is around 7 degrees of squint. How do you depict in prism diopter? It is double, 14 to 15 prism diopter. That is 1 millimeter around double, इसलिए मैंने बोला. So that is 1 millimeter of displacement is equivalent to that. So what are we doing here in this test? So in this test, what we are doing, we are seeing what prism diopter, at what prism diopter, the two reflexes will come at the center. That is the exact amount of squint. So Hirschberg's test is only giving an idea, you know. It is not exact measurement. This is giving exact measurement that, okay, this is the prism diopter of squint or deviation and this is the correct value. So we will answer. This is called Krimsky's test. We can call it prism reflection test, a little different, but this is same, Krimsky's test. Okay. Then we talk about, okay, Maddox rod, Maddox win. We can just discuss that later in some other question. That's a little longer topic. We come to the next image. What is this? So we all know we are looking at dermoid, which is situated at the limbus. This has been a recent question. Keep in mind, this is limbal dermoid. Now, there has been a confusion, I think, even in the recall discussion, but this is what we finalize here is that this is a limbal dermoid, and we can see here the hair is coming out. It has to be this. What about lipodermoid? Have a look. So, generally, the location for a lipodermoid most commonly is from the orbit like this. Okay. So, when we talk about lipodermoids, we have to see a picture something like this. It was asked just as a spot diagnosis. You should be very clear about it. So here I will answer it as dermoid. Okay, so this one is our dermoid. Right, all of you? So this was a quick discussion from my side. Please take all these topics very seriously, and if you think you haven't read it properly, you have to read it. Okay, let's end with another one. So this is the most important part because these are life lessons, and I really value these thought for the days, and I really work very hard to find these thought for the days for you all, which can really influence you all in the most positive way, and you can come out with your maximum potential in life, and each one of you can become very very happy. Okay, so let's see what I have taken out from my research here. I'm reading it for you all. Rather than comparing your every joy and sorrow to that of others, aim to surpass your limits in your current situation and realize your own true potential. Right? Okay? What does it mean? I hope you understood. So, we are talking about running our own race and not comparing ourselves with anyone. Right? Yeah. So, that was all for today. Happy learning. Okay, keep smiling and stay blessed. Thank you so much.